Hello, everyone. Welcome to the GSM MedMint for those who breathe medicine. I am Samar, and today we are tackling one of the most dangerous differentials you will face in the ICU or emergency department at 2 in the morning. The topic is the acute heart failure and the acute respiratory distress syndrome. Both present with the wet lungs, both have bilateral crackles, both need oxygen, but if you confuse them, your ventilator settings can kill the patient. So let us deep dive, keep it simple, and make sure that you never miss this again. Picture this, a 65-year-old patient is brought in with severe dyspnea, respiratory rate over 30. You hear bilateral crackles on auscultation, the oxygen saturation is falling. The chest X-ray shows the fluffy bilateral infiltrates. Now your resident says it is pulmonary edema. Start the furosemide. But wait, what if this is ARDS? If you throw the diuretics at the ARDS, you will dehydrate the patient and do nothing about the leaky alveoli. And what if the patient is in heart failure? But you set the ventilator at as it is like an ARDS situation, the low tidal volume, the high positive end expiratory pressure, the patient will crash hemodynamically. This is why the differential matters. This is why we are here today. So, what is the fundamental question? What is driving the pulmonary edema? It is the high pressure or it is the leaky membranes. So in cardiogenic pulmonary edema, the heart failure, the problem is hydrostatic pressure. The left ventricle fails, the pressure backs up into the left atrium. When then the pulmonary veins, then the capillary pressure climbs up over the 18 millimeters of mercury. The fluid is forced out, but here is the key. The membrane is intact in this case. The membrane is intact in the cardiogenic pulmonary edema. The fluid is a transudate, it is protein poor fluid. In ARDS, on the contrary, the problem is permeability, the alveolar capillary barrier injury. So, the alveolar capillary barrier is damaged, the neutrophils attack, cytokines flood in, and the membrane becomes leaky. Fluid seeps into the normal pressure. Even at the normal pressure, the fluid seeps in, and this fluid is protein rich. So, this is exudative in nature. So, the basic difference here is that fluid in the cardiogenic heart failure is a transudate, and the fluid in the non-cardiogenic ARDS, this is an exudative type of protein-rich fluid. Two completely different mechanisms, two completely different treatment protocols. Let me walk you through the Starling cascade in the heart failure. It starts with the left ventricular dysfunction, maybe an acute myocardial infarction, maybe arrhythmia, maybe decompensated chronic heart failure. The left ventricular end diastolic pressure, it rises, that pushes up the left arterial pressure, that pushes up the pulmonary venous pressure. Finally, the pulmonary capillary pressure, it finally crosses the threshold which is above the 18 millimeter of mercury. Now, remember the Starling equation. Fluid movement depends on the hydrostatic pressure, the oncotic pressure and permeability. No, the fluid leaks because of the hydrostatic pressure exceeding the oncotic pressure. So in the heart failure, the permeability is normal, but the hydrostatic pressure is so high that it overwhelms the system. The fluid shifts into the interstitium and then into the alveoli. The lymphatics try here to compensate, but they are overwhelmed, and the result is pulmonary edema. But the membrane is still intact here. That is why the diuretics work here. You reduce the volume, you reduce the pressure, you leak, and the leak stops. So this is how the mechanism in cardiogenic pulmonary edema works. So go through that again. The membrane is intact, so the diuretics will work by reducing the volume, reducing the pressure, and stopping the leaks. Now the ARDS, the injury cascade is completely different here. The trigger can be pneumonia, aspiration, or an indirect injury like sepsis, trauma, pancreatitis, and massive transfusions. Whatever the trigger is, the result is the same. The inflammatory cytokine storm that causes the neutrophil release, the proteases and reactive oxygen species. The alveolar capillary membrane is destroyed here, and the type 1 pneumocytes are destroyed. The surfactant is lost. Here, the membrane is damaged, the permeability increases, and the surfactant and the type 1 pneumocytes are destroyed. The membrane is now like a torn sieve. The fluid pours through even when the capillary pressure is completely normal. The fluid is protein rich, full of the inflammatory cells. It inactivates the surfactant, causes atelectasis, and creates a massive shunt. That is why the pulmonary capillary wedge pressure stays below the 18 in ARDS. The pressure is not the problem here, the leak is the problem. And that is why the diuretics will not work here. The membrane is damaged, not overloaded. Let me summarize this in a simple table. The hydrostatic pressure is high in the heart failure, normal in the ARDS. The capillary permeability stays normal in the heart failure and increased in the ARDS. The fluid type is transudative in cardiogenic edema and exudative in the ARDS. The alveolar membrane is intact in the heart failure, damaged in the ARDS. The primary driver is pressure overload in the case of cardiogenic edema, whereas in the ARDS it is the inflammatory injury damaging the membranes. Then response to diuretics in cardiogenic edema is good, and in ARDS it is poor or minimal. This table is the mental framework. If you remember nothing, you should remember this. Now, the gold standard for the differentiation is pulmonary capillary wedge pressure. It approximates the left arterial pressure. The PCWP greater than 18 shows the cardiogenic pulmonary edema or the heart failure. PCWP less than 18 indicates the ARDS or non-cardiogenic edema. But here is the problem. You do not always have a Swan's-Ganz catheter in the emergency department. So how do you estimate the PCWP? To estimate that, we first use the echocardiography, the E over the E prime ratio. If it is greater than 15, the elevated arterial pressure is likely, less than 8, probably normal. The second, lung ultrasonography, the diffuse B lines with the pleural effusion suggests the heart failure. The clinical, third, the clinical exam, the elevated jugular venous pressure, the S3 gallop, the peripheral edema, these scream heart failure. Here's a quick word on the PaO₂ over the FiO₂ ratio. This is the severity marker, not the differentiator. Both the heart failure and the ARDS can have low P by F ratios. Normal is 400 to 500. Mild ARDS is 200 to 300. Moderate 100 to 200. Severe is under 100. But do not use this to tell them apart. Use it to cause how your sick patient is. The differential needs the other tools. BNP, the B-type natriuretic peptide, is released from the ventricular myocytes when they are stressed. In the heart failure, the BNP is usually high. We can see the values reaching more than 600 picogram per milliliter median. In ARDS, it is typically lower, under the 250, suggesting the ARDS. So, but this is big. But BNP is not perfect. In ICU patients, sepsis can raise BNP because of myocardial depression. A renal failure can elevate the BNP. In the ARDS, with the right ventricular dysfunction can raise it, and obesity can lower it. So we need to keep in mind these points, that BNP is not perfect, to differentiate it in the ICU patients, because there are many conditions that can cause the rise of the BNP or fall of the BNP. So BNP is a clue as not a rule. So do not hang your diagnosis based on the BNP alone. So here is the big comparison table. I want you to screenshot this. The PCWP over 18 in the heart failure and under 18 in the ARDS. And the BNP usually over 600 in heart failure, so usually less than 250 in the ARDS. P by F ratio variable, and less than 300 in ARDS, but definition. Actually, it's not very reliable marker. So the heart size on the chest X-ray, we can see the cardiomegaly in the heart failure, and it is normal in the ARDS. The pleural effusion common and bilateral in the heart failure, less common in the ARDS. The infiltrate pattern in the central bat wing in the heart failure, and peripheral patchy in the ARDS. The response to diuretics is good, and the ARDS has a poor response. Lung ultrasonography shows diffuse homogeneous B lines in the heart failure, patchy with consolidations in the lungs, in the ARDS. Now, let me teach you the chest X-ray in the lupus style rapid assessment. In the heart failure, look for the four things. One, the cardiomegaly. And the heart size too much big than the normal. Then the cardiothoracic ratio is over the 50%. The second, bilateral pleural effusions, usually right greater than the left one. Three, the central batwing opacities, perihilar fluffy like a butterfly pattern. Four, the upper lobe diversion, the cephalization of the vessels and the curly B lines. You can see all of them in the X-ray provided. So here is the cephalization of the vessels. We can see here the curly B lines, the increased CT ratio, the pleural effusion. This is These opacities are fluffy central and spare the periphery. This is because the hydrostatic pressure is highest in the central vessels. Now in the ARDS, the opposite happens. One, the normal size heart is seen. Second, the peripheral patchy infiltrates can be seen. The central zones are mostly spared. Third, the dense ground glass opacity with the air bronchograms. And fourth, the pleural effusions are uncommon. The opacities are patchy in peripheral because in the ARDS we saw that it is heterogeneous and gravity dependent. The damage is not uniform. So here is a 30-second read. The heart failure, cardiomegaly, yes. The pleural effusion, yes. The infiltrates are central and batwing type of pattern is seen on the X-ray. Curly B lines can be seen. The heart size is increased. And in the ARDS, there is no cardiomegaly, the pleural effusion is not there or minimal. Infiltrates can be peripheral and patchy. The curly B lines, no. The heart size is normal. So train your eyes to look at the heart size first. That alone can help you the 70% of what you need to know. The lung ultrasound is a game changer. At the bedside, in 2 minutes, you can tell them apart. The heart failure, diffuse bilateral, no B lines, which are homogeneous, irregular, fragmented pleural line can be seen. The bilateral pleural effusions, the preserved lung sliding can be seen. So here we can see the smooth pleural line, multiple B lines here, and the anechoic pleural effusion. So in the ARDS ultrasonogram, we can see the patchy or non-homogeneous B lines, and we can see irregular fragmented pleural line, which is a key factor here. You can see the irregular pleural line, and no, the small subpleural consolidations can be seen, as well as the sparred areas between the lesions. Reduced lung sliding in severe cases can be seen. So the pleural line is the key. The smooth and thin in the heart failure and irregular and broken in the ARDS is the key difference alone. This key difference alone is incredibly powerful to differentiate between the two. So the thin and smooth pleural line in the heart failure and irregular fragmented pleural line in the ARDS. The echo is the heart's confession. The heart failure, low ejection fraction, the diastolic function with E over E prime greater than 15, dilated left atrium, the functional mitral regurgitation, and the elevated pulmonary pressures can be seen. And whereas in the ARDS, in echocardiography, we can see normal size left ventricle and its function, normal ventricle filling pressures, and no structural valve disease. You might see the right ventricular dysfunction from the ARDS itself, but the left side is quiet. If the heart looks sick, it is probably due to the heart failure, and if the heart looks normal, so think about the ARDS. So key factor here, the heart is sick, so heart heart failure, the heart looks normal, go for the ARDS. Why does the ventilator strategy matters? Because the ventilator strategy is completely different. If you treat the ARDS like you are treating a heart failure, The high tidal volume, no lung protection, you can cause the volutrauma or the barotrauma. You can worsen the inflammation. And if you are treating the heart failure like the ARDS, your low tidal volume, high positive and expiratory pressure, you compromise the hemodynamics of the patient. So you drop the blood pressure, you delay the diuresis. Getting the diagnosis wrong is not the academic error here, it's dangerous for the patient. So we need to remember the ventilator strategy is totally different in both the situations. So we go to the management of the cardiogenic edema, the 4Ds, the diuretics, the loop diuretics like furosemide, the dilators like nitrates to reduce the preload and afterload, the ionotropes, dolubutamine or milrinone if the patient is hypotensive, and the devices like BiPAP or CPAP, it reduces the preload and improves the oxygenation within the minutes. So the goal is to reduce the preload, improve the contractility, maintain the perfusion, and avoid excessive positive and expiratory pressure if they are unstable. The management for the ARDS, you should protect the lung. The low tidal volume, less than 6 milliliter per kg ideal body weight, the plateau pressure under 30, and the appropriate positive and expiratory pressure to recruit the alveoli, the prone positioning of the patient if the P by F ratio is under 150, the conservative fluid strategy once the patient is stable. So the most important goal here is to treat the underlying cause, the antibiotics for sepsis, source control, because the lung will not heal by itself if the fire is still burning. So now, here are the two quick scenarios. We see scene one, a 70-year-old acute myocardial infarction, blood pressure 90 over 60 and bilateral crackles. CXR shows the cardiomegaly, the battering opacities, the BNP more than 600. So here we will make the diagnosis for the cardiogenic edema. We will give BiPAP, diuretics, and the ionotropes. And scene 2 shows the 45-year-old pneumonia history, fever, bilateral peripheral infiltrates, and normal heart size. BNP is reduced. Okay, BNP is 180, and pulmonary capillary wedge pressure up to 12. This is classic ARDS, and we should give lung protective ventilation and treat the infection, the source. So the key takeaways, if you ever encounter such a situation at the night hour, is one, the pulmonary capillary wedge pressure is a divider. Over 18 is heart failure and under 18 is ARDS. So second, the BNP helps but is not a perfect marker in the ICU conditions. And so third, the chest X-ray, look for the normal heart size, effusions and the infiltrative patterns. Fourth, the lung ultrasound, the homogeneous B lines mean the heart failure, the patchy and irregular pleura means the ARDS. The 5, the echocardiography, the left ventricular dysfunction means that this is the heart failure, and the normal heart, think about the ARDS. 6, the wrong ventilator strategy equals to the harm. Get the diagnosis right and manage the patient accordingly. So the references are on this slide, the Berlin definition, ARDS, net trial, ESA guidelines, and recent literature on the lung ultrasonography. You can read them, it will make you better. Thank you everyone, that's all for today. If this helped, you can hit the like button, share it with your friends who are struggling with the ICU differentials, subscribe to GSM MedMint for the more content like this. Remember, we do not just study medicine, we breathe it. Thank you and see you in the next video.